Okay, we are at the top of the hour. Hello, and welcome to our fourth quarter Program Integrity Pulse webinar, Preparing for Investigative Strategies in 2024. I'm Warren Lesniewski, VP of Product Marketing here at Cotiviti. Thank you so much for joining us today. We are fortunate to have two of our senior fraud, waste, and abuse investigators presenting today, Mary Kate Anderson and Mundy McFadden, and I'll have them introduce themselves in just a moment. We also have Erin Rutzler, our VP of Fraud, Waste, and Abuse, and she will join us for the Q&A at the end.
Today's main objectives we would like to go over with you today will first be to reevaluate our investigative strategies and plans. Second, to acquire knowledge of CPT code changes. And third, to learn about upcoming potential FWA trends. And we will accomplish these objectives today by discussing and diving into what all should go into investigative work planning, providing a high-level view of 2024 CPT code changes, and to what to expect with those. And lastly, reviewing FWA trends, such as for the new weight loss drugs known as Ozempic, Wegovy, and semaglutide, as well as reviewing a COVID-19 testing scheme and home infusion therapy. And with that, I'm going to go ahead and dive in today with discussing investigative work plan preparation and how having an investigative work plan can benefit you and your company. To start, it is a flexible guide tailored to your organization. It considers new and emerging trends, focuses on recommendations to pursue in the coming year, and includes investigative strategies to prepare for specific trends. For example, each year, Cotiviti drafts a new investigative work plan for their clients that takes any new information and trends into consideration when exploring healthcare data to identify potential fraud, waste, and abuse. And a good investigative work plan takes new and emerging trends into consideration and is tailored to your client based off of recent data. So essentially, this is like a bird's eye view of what we will most likely see in the next year. So it is more of a guide or a roadmap to help you and your organization assess areas most vulnerable to FWA and facilitate in those investigations. And when writing your work plan, since we have data from the most current past year, we can use that as a basis for what we saw and what schemes were most prevalent while drafting the work plan. However, you should also focus on any new trends, recommendations from HHS OIG, any coding changes from the American Medical Association and coding guidelines, and etc. when planning for the upcoming year. Now, what to include in your work plan? When you are report gathering, there are a few areas you want to make sure to consider, such as lines of business. One work plan may encompass multiple lines of business, or you might have a work plan for each specific line of business. You may only work with Medicaid, or you may even have payers in the Medicare and commercial lines as well. You also want to utilize your client payment policies, medical policies and guidelines, data analysis and spike reports, most recent claims data, and SIU internal reports as well. And just a note, your look-back period for data utilized in the work plan is the most recent year, but it should primarily focus on recommendations to pursue in the upcoming year. And then you have your external resources to consider. The U.S. Department of Health and Human Services Office of Inspector General, aka HHS OIG, issues a list of active work plan items, which are audits that are in progress or planned. So the HHS OIG assesses risks and sets priorities when planning, but makes updates each month to adapt to emerging issues. And while we issue a work plan yearly, it is a helpful tool to see what is on HHS OIG's radar and to check in periodically to see if any risk they've identified could affect your audits as well. The Medicare Payment Advisory Commission, also known as MedPAC, advises on issues affecting the Medicare program. CMS Health Plan Management System collects data and reports on the Medicare Advantage and Part D programs. And most recently, the American Medical Association, also known as AMA, contains coding guidelines and also any coding changes, additions, or deletions. So this should be considered as well when drafting your investigative work plan. And lastly, your state's Medicaid fraud unit is a great resource as well. Okay, so now for your points of interest for your investigative work plan. The highest paid line of business can help you or your client determine which payers have the most exposure and could be likely targets for exploitation. So top paid procedures and services. The highest paid specialties may reveal what areas are most at risk, new codes that have become areas of exploitation, and that would be recommended for further review and analysis. And along with specialties, you will want to drill down within specific services, such as those evaluation and management services, also known as E&Ms, behavioral health, physical therapy, etc., to see which providers have the highest exposure. And you may already have a current open investigation on a provider or have audited them in the past, but the work plan can recommend additional analysis due to the new trending data. Also, a visual, such as a graph, that really helps you see the amount of revenue one code generates and should be included in your work plan for risk assessment. So as you can see, the pie chart to the right is focused on behavioral health codes, but you can see CPT code 90837, which encompasses a 60-minute individual psychotherapy session, is the highest paid service and could potentially be an area of concern based off this payment trend and should be closely monitored. And from my experience, when really reviewing the data, a potential scenario in this case could be a provider maybe providing group therapy services, especially to families, for example, but is billing for the individual therapy service code per patient to obtain that higher payment. And to really substantiate this, you would really need to dive deeper into the data analysis, reviewing medical records, medical review for proper billing, and interviewing staff and members of the provider as well. And then also just a note that reviews are focused on, but not limited to, the procedures and trends outlined in the work plan. Again, going back to the work plan being an overall guide of what to keep in mind, keeping the next year in your mind. And moving into things to consider for 2024 while drafting your work plan. The end of COVID-19 public health emergency. The public health emergency for COVID-19, it ended on May 11th, 2023. However, we do recommend continued monitoring of billing for COVID testing for in and out of state laboratories, employer group testing, and other related schemes. So still look at those top providers for COVID-19 testing as well. For a resource, CMS has issued fact sheets and facts regarding the end of the COVID-19 public health emergency that outlines what will and will not change. And I do have the link listed there for you as well. And another area to keep an eye out for is pharmacy claims. The opioid epidemic is still rampant, and HHS OIG continues to monitor claims data to identify patterns and mitigate opioid abuse and questionable opioid prescribing. With those claims, you will want to look at providers who are outliers of prescribing opioids in their field of practice, starting with identifying providers who are ordering high amounts of opioids for a larger number of patients. Also look at providers prescribing Schedule II drugs without a corresponding patient visit, or for patients they have never seen. That's a huge one. The OIG's list of excluded individuals and entities is always a great resource to keep yourself familiar with while carrying out investigations and is up to date. And again, you may already have an open active investigation on a provider, but recommendations for additional analysis are encouraged to identify new suspect exposure. And now that we have gone over investigative work plan preparation, we can move into 2024 CPT code changes. And at a glance overall, the 2024 CPT code set, it will include 230 additions, 49 deletions, and 70 revisions. So first, we have the change. The AMA added 5 new codes, and these codes are product specific and will help improve reporting and analysis of RSV immunizations, which will support data-driven planning and allocation. And currently the RSV vaccine, it is covered under Medicare Part D, in some private health plans for adults 60 years and older, but the RSV vaccine is not yet included on the CDC's annual vaccine schedule for adults. And until it is included, private insurance plans can choose if they want to cover it or not. And that leads us into the impact of the change. There could be abuse of a new vaccine, such as advertising early access to it. Providers may advertise early access to the vaccine in exchange for a deposit or fee, or some doctors may ask you to pay out of pocket for the vaccine. While some insurances may not cover the vaccine, be wary of providers requesting for a patient to pay out of pocket up front. With that, also watch out for providers offering to ship doses of a vaccine to a patient's home for payment, as this was an issue that HHS identified and pointed out that was happening with the COVID vaccine rollout. And then we have RSV testing. RSV testing is under CPT code 87637, which also includes COVID, but is less commonly used than the COVID-19 antigen testing CPT code 87426, which we do see more of. However, it is still the same fraud scheme of services being billed but not rendered, so you will want to make sure to check the place of service in the patient's residing state versus the provider's location. Look at billing for testing on consecutive days for the same patient, and that the provider has a clinical lab improvement amendment certificate, also known as a CLIA certificate. And our next area of focus is evaluation and management services, also known as E&M services. So to start with the change is that the AMA removed time ranges from new and established outpatient codes, those ranges being 99202 through 99205 and 99212 through 99215. The removal of time ranges aligns these office and outpatient codes with other E&M codes, and the time that needs to be met is the lowest number of minutes in the current code range. So for example, E&M code 99202, which is an E&M for an office or outpatient visit of a new patient, has a current time range of 15 to 29 minutes. But beginning January 1st of 2024, the provider must meet or exceed 15 minutes of total service time before they can bill this code by time. And so with this change, now there is only a single time amount that needs to be met or exceeded. Now we move into the impact of this change. Upcoding of E&Ms is still persistent. You want to ask yourself the question, do you have any providers who are outliers against their peers for billing those higher E&M visits, such as level 4 and 5 E&M visits? You know, the addition of modifiers, such as if a provider is appending a modifier 25 to every E&M code billed alongside other services, you'll really want to drill down and look at what those other services are. If the additional services are permissible to being billed separately from that E&M code with that modifier 25, and if it is determined that the medical records support the E&M being billed as a separately identifiable service. And with that, we also have the unbundling of services to watch out for. And then specialties most at risk, we have internal medicine, family practice, and emergency medicine, being they are some of the highest paid specialties. There's usually a lot to look in that data. And to give you all a visual of this specific change with the E&M's time, we have a chart for you to look at the current guidelines versus the new guidelines for 2024. So on this chart, on the left of the chart, you have here what is the E&M code current time ranges, and on the right, you have the new changes implemented for January 1st, 2024. That shows the minimum time that needs to be met for each code, and the provider must document that minimum time to support that code. And to expand on the impact with this change of E&M codes, we normally see impossible days with psychotherapy. But with potential upcoding of E&Ms, these time-based codes can be low-hanging fruit to investigate especially when we get into more of the frequency of the higher level E&Ms being billed. So impossible days occur when a provider bills for more time services than are possible within their hours of operation or hours in a day. But if an E&M code is submitted in conjunction with an add-on psychotherapy code, such as 90833, 90836, 90838, which results in more payment, the treatment note should support the separate and distinct E&M and documentation and should distinctly support the psychotherapy. With the impossible days, you want to look up at the stacked up service codes. Is there enough time in the day to be billing an evaluation and management and a psychotherapy code with every visit? And to expand a bit more, the E&M becomes the parent code and psychotherapy becomes an add-on code. So the E&M time cannot support the psychotherapy time since being a time-based add-on code, and the EM should be supported by patient exam and medical decision-making. And then just as a side note, just reviewing of medications does not solely justify an E&M. So a provider cannot bill an E&M with an add-on psychotherapy if they're only looking at the medications. That does not justify the E&M. However, a separate diagnosis is not needed for an E&M and psychotherapy visit each time or each date of service. So keep in mind that the pattern of the same diagnosis for both the E&M and psychotherapy for all patients may yield a false positive in your data analysis. And then just a final note on E&Ms, the time is the face-to-face and non-face-to-face time the provider spends on the encounter of that date of service. So total time can include reviewing tests before the patient is present, coordination for care after the patient leaves, and time required for the visit. So in conclusion, providers simply cannot double dip. Going back to spent on the E&M cannot be used for the psychotherapy as well. They must be documented as separate and distinct services. And just to summarize with all of these factors to consider with, impossible days or evaluation and management codes, you want to look at your daily hours of operations with a provider. Is the provider billing claims before their posted opening time or even after their posted closing time? Look at the number of practitioners performing treatments. Could the number of practitioners providing those services justify the amount of treatments in a day being billed? And then you want to consider patients from other payers being seen on those days as well. A practice will see multiple patients a day. So if you have a provider billing multiple treatments a day for your members alone, really ask how many hours of service a day are they billing for patients from other payers. And then you also have cloning of records, duplicate medical records for different patients. You'll have some medical records that are the same copy and paste patient identifiable factors present across multiple factors. That's another huge one to watch out for. And then lastly, pattern of high or low E&Ms being billed. How does the provider's billing stack up against their peers? And really just looking out for any outliers that catch your eye. As stated earlier, is a provider consistently billing those level 4, 99214, 0405 codes compared to their peers? Those are going to be where the big money lies.
Ozempic, Wegovy, and semaglutide, they are still in the forefront. I know lots of people have heard lots of different things about these medications. Ozempic is FDA approved for the treatment of diabetes, and Wegovy is FDA approved for weight loss. The demand for these two drugs has become extremely high, and it has made these medications, the Ozempic, hard to come by. So the thing about these two drugs is Ozempic and Wegovy have the same active ingredient, semaglutide. Therefore, Ozempic can be used for weight loss. And a lot of people have figured this out, and they have been getting their doctors to off-label prescribe Ozempic for them whenever their plans don't cover weight loss medication. Ozempic has been being prescribed for weight loss and not diabetes, and this has caused a really big medication shortage for those individuals who need this medication to control their diabetes. Medicaid and Medicare do not cover weight loss medications. Therefore, some providers have turned to the off-label prescribing so that they can prescribe Ozempic for the weight loss and not for diabetes, which again has created this increase. Some commercial plans that do cover weight loss medications, however, not all do. If you have the opportunity, review your plan to determine if your plan covers these drugs. If your plan does not cover these drugs, it would be really important for you to start looking at the increased prescribing of Ozempic. And then we're going to move into some of the things that investigators should be looking for as far as catching bad actors. Review your plan's coverage to determine if there's any coverage for weight loss services. Look at the prescribers prescribing this medication. Since Medicare and Medicaid do not cover weight loss medications, look for the overprescribing of Ozempic. Whenever these prescribers, want to prescribe these medications, they'll figure out a way to prescribe it and get it to their patients, because they always tend to want to make their patients happy. So if a patient comes in and wants to lose weight, but their plan won't cover it, then they're going to find a way to get the medication for them. As well as some are doing semaglutide, and they're going to pharmacies and having them compound those drugs for them. And the thing about that is that some of these drugs that are being compounded either don't have the right ingredients, or they might have wrong ingredients in it. It's making people very sick, different things like that. Whenever you're looking at the physicians, you want to see what type of prescriber they are. Are they a weight loss physician? Are they a primary care physician? Are they an endocrinologist? Review the claims and medical records to see if they're supporting lab work and that supports the diagnosis of diabetes. Prescribed other diabetes drugs in the past, or if they if the member has previous diabetic claims, diabetic supplies, etc., like that, things like that. You just really want to keep an eye out on these two drugs. The biggest thing to be looking for, especially if you work in the Medicare and Medicaid realm, is the high prescribing rate behind Ozempic. Due to Ozempic and Wegovy, those two drugs are so similar, they pretty much act the same way. So a doctor might say an individual is pre-diabetic and they'll prescribe Ozempic for them. However, there's no lab work. There is no paper trail to prove that this person is pre-diabetic, but they are taking the medication to lose weight. Therefore, the insurance is paying for it, and it's a very expensive drug. So moving on, I'm going to ask you guys another poll question. I'm very curious to see how many of you out there have found any fraud, waste, and abuse with these drugs. A is yes, B is no. I'm not sure that, people, it depends what type of investigations you do, if you do pharmacy investigations or if you're doing provider investigations. If you're seeing these different trends or not with these types of providers. So it looks like about a 70-20 between yes, about 28% have seen some fraud with this and are some cases, and as well as about 72% have not. I've put this slide up here. I just wanted to, at the end, you guys will be able to get this presentation. I wanted to include this information. Melanie Poole, our SIU Director of Fraud, Waste, and Abuse, she wrote an article regarding Wegovy and semaglutides and Ozempic, and it goes into greater detail talking about different things that you can look for, different questions you can ask, data, how you can analyze your data, things like that. So I wanted to include her article that you could go back to and really use it whenever you start diving in and trying to find some of these bad actors that are actually conducting fraud and prescribing these medications off label. And moving into Zepbound. Zepbound is, it's kind of in the same family as Ozempic and Wegovy, but it's got a little bit different ingredient with it. But the FDA just approved this new weight loss drug. It is made by Eli Lilly. Zepbound is a new weight loss drug that it hit the market, I think, December 5th. It's very, very new. It has similar ingredients as Mounjaro, which is like Ozempic and Wegovy. They're sister drugs. This is the same concept here. However, studies are showing that Zepbound and Mounjaro, you lose even more weight. So it is, I foresee this drug probably going to become even a larger prescriber for those plans that cover it. And I think that Mounjaro, you're going to see the increase in that drug being prescribed. They're both glucose dependent GLP-1 hormone receptor drugs, which until, it helps the body it holds food in the system and helps you to lose weight. It's supposed to curb your appetite. This drug is the first and only obesity treatment of its kind. So it's going to probably become super popular eventually with the larger weight loss than Ozempic and Wegovy. But definitely, I think my key here is to keep your eye out on looking at the overprescribing of Mounjaro because of the Medicaid and Medicare not covering weight loss drugs. Therefore, this is going to be another one where they're going to resort to prescribing the Mounjaro. Also, if the commercial policy covers weight loss drugs, it's imperative to ensure the patient's diagnosis and test results fall within the weight-related medical problems listed for drug prescription approval. So it does have some key factors that you need to be able to fall within, and they have them listed. One of them is hypertension, type 2 diabetes, obstructive sleep apnea, cardiovascular disease. There's a couple other things that you really need to look for. Adults with obesity, they have a BMI of 30 kilograms or more, and adults who have, some of these other obesity weight-related issues in order to receive the Zepbound. It's not just one of those medications that they're just going to prescribe because you're overweight. There are certain things that criteria you need to meet in order to receive those medications and for the plan to cover those medications. Next, I want to talk about COVID-19 testing. Like Mary Kate said, COVID-19 testing, don't let that fall out of your minds. Don't let it go away, because COVID-19 is not going away. I read almost daily articles where COVID-19 people are being diagnosed daily, being admitted into the hospital. I think it's here to stay. It's definitely the billing behind COVID-19 you're going to continue to see spikes within that. One of the things that I saw with a provider that I was looking into, I saw some suspicious activity with this provider. I noticed whenever I was conducting data analysis that this provider was billing for in-person COVID-19 testing. And then I looked where the provider was located, and then the provider was located in one specific state. And then all of the individuals that were being tested were located, a couple states away, maybe 3 states away, 1,000 miles away. I started really doing some mapping on it and noticed that there was just no possible way that these individuals could be going into this office and getting in-office testing. And then I also looked even a little bit further, and the provider was billing the COVID testing 3 days in a row. And he billed that for every single person that he billed for. So not only was he billing for individuals that lived states away, thousands of miles away, he was billing it in 3 consecutive days. So therefore, I wrote up an investigation regarding this. And after digging really deeper into this, what it was determined was this individual was actually sending out the home test. So he was billing for an in-person test when it was a home testing kit, which there's a huge difference in price. And some of these individuals didn't even order these tests. They didn't want these tests. They didn't ask for these tests, but he was still billing for 3 days in a row. They didn't get 3 tests. They only received 1 test. And the thing with the testing, you're supposed to wait 7 days before you repeat a test. But one of the things that you can look for whenever you start looking at your COVID-19 testing is look at your place of service. And if it says 11, which means office, then look and see where those individuals are located. And if they're located pretty far away, then you might want to do a little bit deeper dive and see if these tests are actually legitimate. And in this case, are they receiving mail test, or are they, were they going in person? And I have on here the rates, $20 to $850. It's a huge difference. And also look at the days. If they're billing consecutive days, you definitely want to look deeper into that provider. Providers have definitely found ways to try and get away with overbilling of COVID testing. So I have a poll question for you guys. You can bill COVID tests for more than 1 consecutive day. A, true, or B, false? If you were listening, I just gave you the answer. And it looks like everybody was listening. Looks like about 85% of you said false. That's awesome. All right. So our next topic that I want to talk about today. This one is, I've actually done quite a bit of investigating regarding home infusion therapy. Home infusion therapy is the intravenous or subcutaneous administration of drugs or biologicals to an individual at home. The thing about home infusion therapy is it's a great service that's offered to individuals that can't leave their home. The components that are needed for this are to perform the home infusion therapy include the drug, the equipment, and supplies. And visiting nurses often play a large role in home infusion therapy. Nurses typically will train the patient and caregiver to self-administer the drug. They'll educate them on side effects and goals of the therapy and visit periodically to assess the infusion site and provide dress changing. Within the home infusion therapy, there are 3 different payment categories. So you have your category 1, which includes certain intravenous, antifungal, and antivirals, uninterrupted long-term infusions, pain management, and inotropic and chiliatin drugs. It's not a word I can say very well. And then category 2 it includes your subcutaneous immunotherapy and other certain subcutaneous infusion drugs. Then category 3, it includes certain chemotherapy drugs. And whenever you're conducting your data analysis, you would want to look, you would want to look for claims. You want to look at the different times of the year. Times that you have a permanent benefit and then you had a temporary benefit. So when looking at the claims in calendar year 2020, that was your temporary COVID, your emergency temporary benefit. And then your permanent benefit started claims after January 1st, 2021. So they kind of made some pretty major changes within the home infusion therapy. Those changes first was under the temporary, only DME suppliers could provide home infusion therapy, which is also called HIT therapy. And then under the permanent, any qualified HIT supplier who is accredited and enrolled in Medicare and Medicaid can provide these HIT therapy services. This will increase the market for new providers to be able to commit fraud. Whenever it was just the DME providers, you had a very small amount of people who were providing these services. It was around about 48 providers throughout the United States were providing these HIT therapies, which seems very small. And that's why I feel like some of the cases that I've looked at, I saw a pretty large amount of inappropriate billing, maybe because there's so little of them that were providing the service and they just were kind of doing a sloppy job with the services that they were providing. So pretty sloppy paperwork, as well as their notes and things like that. That's one of the things that I saw. And under the permanent the new rule is they had removed a couple of drugs from the permanent benefit, which is, it's only 3 drugs, morphine and Zemplify. It was morphine was removed, ziconotide and fluoxetine, and then 1 subcutaneous immune globulin drug, Zemplify, was added. So when you're reviewing the data, keep this in mind. You have G codes, which are the professional service for the administration of the drugs. Along with this code, a length of time will also need to be provided by the number of units that are used for the individual giving the immunotherapy. The number of units will correspond to a different length of time. It's not always going to be the same, so there wouldn't be an approved number of units in order to give this medication. The S codes are home infusion therapy via IV administration of the medications or fluids. And the J codes are the infusion drugs. The person administering the medication will also bill they will bill for all those 3 as well as the units again. And you want to make sure whenever you're looking at the records that the units correspond with the record and assigning in and signing out time. Also, you want to make sure that the HIT provider is a qualified provider. You want to make sure that they are a pharmacy that is approved to provide infusion therapy. Whenever you look on the pharmacy board, it will say in there if they have been approved to provide infusion therapy. Whenever you request your records, these providers, generally, you're going to go to the DME if it was during the temporary time. If not, then you will go through probably the pharmacy to request the records. So you'll have 2 different places that you would request the records. But generally, if it's the DME with the pharmacy, then you go straight through the DME to get the records from them. And then I wanted to talk about a case that I had conducted. It's been a little while since I worked on this case. It was a DME pharmacy providing HIT services. The provider was selected due to data analysis. Whenever I was conducting data analysis on DME pharmacy providers that were providing home infusion therapy, this one provider was a top outlier, way among their peers. Very, very large span of difference between billing. And so I requested the medical records after I had conducted a statistically valid random sample, and the records were requested, the records were received, and we had our medical team review the records. Well, the most egregious errors identified in the review was that the documentation just was not sufficient enough to support the claims that were billed and that were paid for by the plan. Delivery tickets were missing. There was no documentation to show service was even provided. No physician or order documented showing that the service was that the primary care physician had even requested this service to be conducted. The signatures were missing. There was missing prescriptions. A lot of different things were missing within the records. Therefore, that case turned into over $2 million in overpayment, which is huge for the provider. For our client, to provide to have been paid this much money when they hadn't been providing these services. They don't have the documentation to back this up, and so just looking into this type of billing is really good for you to help save money for your client that you're working for. Anyway, I have up on the screen right now requesting medical records. That's one of the things, and this is what helped us to be able to find this amount of overpayment for that particular provider. You have to request very specific things whenever you are requesting medical records on a home infusion therapy provider. And I'm not going to read through all of these because we're kind of running short on time, but you'll have this whenever you get the slide deck. And if you start looking into home infusion therapy providers, this will really help you in building your case and catching those bad actors out there. Anyway, I want to thank everybody for being here today, and I'm going to go ahead and hand it back to Mary Kate. We're going to kind of summarize, and then we'll move into some question and answer session. Mary Kate?
Thank you, Mundi, and thank you for all that information regarding FWA trends. So today we started off learning the steps in investigative work plan preparation. And so you have the what and the why. So the why, it is a tailored guide to your client, and it considers new and emerging trends, as well as uses strategies to prepare for specific trends, and also what to look out for in the upcoming year. And then you have the what. The what is involved to create an investigative work plan is you want your report gathering to consider the lines of business, client payment policies, medical policy and guidelines, the data analysis and SIU reports, and then you also want to consider your external resources. So you want to utilize the HHS OIG work plan, the Medicare Payment Advisory Commission, CMS Health Plan Management System, American Medical Association coding guidelines, and then of course your state's Medicaid fraud unit. And then secondly, we reviewed some of the 2024 CPT code changes. So you'll just want to make sure to familiarize yourself and your team with all 2024 CPT code updates to ensure providers are billing properly. And the CPT code changes include 230 additions, 49 deletions, and 70 revisions. In the areas of focus we did discuss today were RSV immunization code additions and the time changes to the new and established outpatient E&M codes, where the time ranges were removed and the time that needs to be met now is the lowest number of minutes in the current code range. So now this update aligns these codes with other E&M codes. And now I will pass it back to Mundy to discuss the key points in her review of FWA trends. Mundy?
Hey, thanks, Mary Kate.
Mhm.
Just want to summarize real quick the FWA trends that I went over. One of the big things, you guys watch out for Zepbound and Mounjaro, as well as Ozempic and Wegovy. The overprescribing of the actual diabetes drug in place of the weight loss drug, as well as the COVID-19 testing that hasn't been conducted in person. It's mail at home test. And then also the home infusion therapy. It's a big one that I've just kind of started to scratch the surface. And with the first case, $2 million. So that I feel like that area is going to grow. And I would definitely be looking out for those. When you do your data analysis, look at the J code where the place of service is 12, which is at home. So that will really help you in your data analysis and be able to drill down what you need to look for.